So, welcome everybody to, I guess, our second developmental rounds of 2025. And today we are fortunate to have Dr. Alison Cox with us from Brock University. Are you in St. Catharines?
Currently, no,
Ah, okay. But that's where you're based.
but that is where I'm based.
Yeah.
Absolutely, yeah.
And I think that having known Alison for a few years in various ways, I think that my sense, as you've always said, sort of this, I don't know if eclectic is the right word, but a real goal to sort of try and merge two fields that don't talk enough, I think, with psychiatry and behavior analysis. And they're almost as though, I think in a lot of ways, people view it as two separate worlds, which shall never meet. And that's a huge problem because we work so much together, especially on really, really difficult clients or patients. So Dr. Cox completed her PhD in psychology at the University of Manitoba in 2015 and is a doctoral level board certified behavior analyst and a registered behavior analyst as well. As an assistant professor in the Applied Disability Studies program at Brock, her researches are diverse and include applied behavioral pharmacology research, tool development and training research, and program evaluation. Through her current and past research and clinical experiences, Dr. Cox has developed specific expertise in assessing and treating severe challenging behavior in individuals with dual diagnosis and acquired brain injury, supporting skill acquisition in individuals with dual diagnosis and autism, and supervising early intensive behavioral intervention programs. Dr. Cox has published in several prominent behavior analytic journals and serves as a peer reviewer across a range of journals in the disabilities field. And I think, my knowledge of Alison is that you're very methodical and rigorous as well, though, in our approach to things, which is how we should be, frankly. But a lot of people aren't, unfortunately. And NSA has this real interest in sort of trying to merge these two fields that we need more people doing similar things. So today, Dr. Cox will talk to us about behavior analysis and psychiatry and underutilized partnership. So, Alison, thank you for joining us.
Thank you for having me. Yeah, I appreciate that introduction. Thank you so much. Thanks for taking the time, everyone, to attend this talk on, something I'm quite passionate about, applied behavioral pharmacology. And an indirect goal of my work, as Rob was saying, is fostering this collaboration between prescribing professionals and behavior analysts to maximize client outcomes. But we'll get to that shortly. So I'm hoping the next hour you're going to come away with being able to summarize the status of applied behavioral pharmacology literature, being able to identify important components that comprise objective data collection systems developed to monitor psychotropic medication effects in the treatment of challenging behavior in individuals with disabilities, and be able to identify where opportunities to leverage a partnership between these two professions may exist in your practice. But at the very least, I'm hoping folks are going to start thinking about how they could improve upon their current practices in monitoring the behavioral effects of psychotropic medication changes that are experienced by the clients that they're supporting. For prescribers in the audience, perhaps start asking questions to care providers or the clients themselves as to whether or not they've enlisted the support of a behavior analyst and whether that behavior analyst might consider participating in the next case conference, at which point prescribers might consider inquiring with the behavior analyst concurrently supporting the client, how they may be able to leverage their skill set, the behavior analyst skill set, such that they can contribute, so that behavior analysts can contribute meaningfully to the psychiatric process. If the medications, of course, are being trialed to address challenging behavior. If I have any behavior analysts in the audience, perhaps inquiring whether it makes sense for you to attend the next psychiatric appointment, maybe asking if it's okay for you to attend so that you can offer your expertise where and if it's appropriate. The loose outline for the next hour or so, less, trying to get all this in, stick to the timeline I was given, is, first I'm going to review relevant psychotropic prevalence literature. Then I'm going to share where the current research on the intersection between medication use and behavior analysis is. Third, we're going to talk about some ways that behavior analysts can monitor behavioral changes coinciding with psychotropic medication adjustments, and that will largely be accomplished by taking you through a medication monitoring tool that I developed and evaluated as part of some behavior analytic training work. This will serve as a nice segue into a description of some research outcomes that resulted from collaboration between myself and some behavior analytic colleagues and their consulting psychiatrist. I'll end by describing some ongoing research in my lab, which exemplifies the application of the medication monitoring tool. So some demographic research has reported that up to 50% of individuals with intellectual and developmental disabilities engage in challenging behavior. And this has been described, the challenging behavior has been described as behavior that may result in physical harm, environmental disruption, and create barriers to social integration and independence. Typically, treatments include psychopharmacological interventions, which are prescriptions for psychotropic medications. And these are chemical substances that cross the blood-brain barrier, act upon the central nervous system, altering mood, thought processes, and behavior. Behavioral interventions are also commonly applied, and these are established on the basis of what we call behavior function. That is, the field interprets challenging behavior as learned performances or behavior that serve a specific purpose for that individual. We often refer to this as behavior function. That is, the behavior functions to produce a change in the environment. Individual information on this facet informs behavior analytic programming, but there'll be a little more on that later. Generally speaking, an individual's behavior could produce an internal change, some sort of sensory experience, or an external change, removing or adding a person, place, or thing from a setting. A simple example might be a child tantruming in a grocery store so that their parent will purchase them a chocolate bar. Once the chocolate bar has been purchased and given to the child, the tantrum stops. A riskier and perhaps more complicated example might be an adult, let's call him Bob, engaging in highly dangerous behavior like physical aggression with a weapon, when someone challenges his perspective for the purpose of making that other person recant. For instance, Bob makes a controversial claim. Hitler was a tremendous leader. Another individual in that setting might challenge that by stating he was responsible for one of the most horrific events in history. He is a terrible leader. Bob then escalates and picks up an item in the setting, attempting to hit the other person, stating, "You take that back." If the other person recants and Bob stops his aggressive episode, then it could be said that the physical aggression served to access a specific outcome, in this case, the recanting of the statement of the other individual. While behavior interventions options may be wide-ranging, one common approach includes maybe essentially manipulating contingencies such that reinforcement is provided on the basis of appropriate behavior. So reinforcement in behavior analysis is defined as the additional removal of a stimulus or stimuli to increase the probability that the behavior will occur again. So in Bob's example, because the other individual recanted their statement in response to his physical aggression, it may be more likely in the future that Bob will resort to this violence in similar situations, wherein he is attempting to access a specific outcome. It follows that interventions can range from functional communication training to extinction. Extinction simply means you're withholding reinforcement in response to the challenging behavior. We can manipulate reinforcement schedules. That is, how often are the behaviors reinforced in order to change how often they're occurring. The list of interventions go on and on. The examples above kind of exemplify situations where isolated reinforcers are like the driving force behind behavior, and there's certainly more complex scenarios where a behavior may be multifunctional. A comprehensive overview goes beyond what I have time to do here today. Of course, I'd be happy to talk your ears off about it, but I did need to give you a titch of a background just so that you kind of know where I'm coming from when I start talking about functional analysis. And its relevance in the context of medication or evaluation or monitoring in that way. So getting back to our list, at times we're also seeing the concurrent application of psychotropic medications and behavioral interventions. So we've got those three types of approaches. Presently, demographic research exploring psychotropic medication application in individuals with intellectual and developmental disabilities and challenging behavior have reported that between 25 and 45% of these folks are taking medication as a form of treatment, while up to 45% of folks comprising that clinical population are taking 3 or more concurrently. This is also called polypharmacy. Of relevance to this presentation is the fact that Lunsky et al. Concluded that current psychotropic prescription monitoring practices are inadequate and do need to be addressed. This shortfall also seems to be reflected in the research realm as well. That is, studies leveraging single case experimental design methodology, as well as case studies to examine the impact of psychotropic medication on challenging behavior in persons with intellectual and developmental disability, tend to be poorly executed. My lab and I examined this phenomenon recently, and the purpose of this paper was twofold. First, using an evidence-informed quality indicator checklist, we provided an update on the rigor of applied behavioral pharmacology research. Spoiler alert, we only found 55 published studies in the last 20 years, which may suggest the topic is relatively understudied. The median rigor score was 57% with a range of 32 to 81%, suggesting that in general, we're not seeing some really great rigorous work on this topic. There's some room for improvement. The second objective was to help clinicians gain a fulsome understanding of single case experimental design, and case study research status, while also providing some possible solutions to barriers that may be interfering with quality research on this topic. So in addition to uncovering the relatively poor rigor associated with this collection of work, we also discovered that folks seem to be primarily relying on indirect measures to capture medication effects, largely ignoring objective monitoring, including monitoring for side effects. This could be problematic because individuals with intellectual and developmental disabilities often have co-occurring communication deficits, and so they can't accurately share their lived experience. For example, the presence of grogginess, fogginess, agitation, nausea, headaches, even improved symptomology as they're experiencing that medication trial. It is true that caregivers can provide insight. However, it might be short-sighted to rely on this as the only monitoring mechanism, in part because some of these private events, so headaches or things like that, may be difficult to reliably identify across observers. For instance, one support personnel may describe the presence of a headache coinciding with specific behavior, while another support person might describe other behaviors as indicative of a headache. Thus, reporter reliability may be called into question, and this could make things trickier for prescribers to make decisions around the next treatment steps. Moreover, the accuracy of indirectly reporting by proxy can be influenced by the reporter's bias. For example, if a care provider believes that a medication will help, they may interpret behavioral episodes more favorably after a medication has been introduced. Alternatively, caregivers who do not ascribe to medication as a viable solution for challenging behavior may be inclined to describe episodes following the introduction of a medication as more troublesome. Other things like primacy and recency effects can impact reporting accuracy as well. So in addition to some of the limitations associated with solely using proxies to provide insight on medication effects, there is another worthwhile reason to highlight. And this might provide additional rationale for the importance of developing that systematic medication monitoring approach. This finding is that a larger proportion of individuals with autism experience adverse side effects to some medication compared to matched neurotypical participants. This slide depicts early work on this topic, specifically looking at methylphenidate and its effects on folks with ADHD and those with comorbid ADHD and autism. The methodology of this work had researchers testing or trialing the drug on an individual's to evaluate their capacity to tolerate the medication before they could be deemed eligible to participate in the study. 18% of children with autism and comorbid ADHD experienced adverse side effects before the study even started and therefore could not participate. This is compared to approximately only 1% of the children with ADHD but no autism diagnosis who experienced adverse side effects. Moreover, this group, the children with ADHD and no autism diagnosis, often experienced better outcomes as they relate to the medication prescription. More recently, Charlotte et al. Have iterated that these outcomes, where's my Charlotte? There she is, have iterated that these outcomes we're seeing this again in neurotypical or neurodevelopmental disorders, in that folks who are experiencing this experience adverse side effects with psychotropic medication at a greater rate than observed in neurotypical populations. So even more than 20 years later, we're still seeing that information being shared. So I'm hopeful that by providing these insights, I'm offering reasonable rationale in support of bolstering medication monitoring practices. And I might humbly suggest that behavior analysts may be well suited to support this type of an initiative. That is, in general, behavior analytic training heavily emphasizes direct objective measurement systems, leveraging behavioral indicators to inform assessment and corresponding intervention impacts. We have well-researched assessment methods to examine both challenging and adaptive behavior changes and use these methods to determine behavioral changes that coincide with our own intervention application. One particularly well-researched assessment is called a functional analysis. This approach was first described in 1982 and since then has become what is known as the gold standard for assessing challenging behavior. Rigorous meta-analysis have suggested that behavioral interventions that are informed by a functional analysis coincide with better client outcomes. That is, treatments that are informed by the results of this functional analysis are associated with larger effect sizes. So several years ago, my then advisor and I were interested to see how many folks in our field had utilized functional analysis as a way to explore drug behavior interaction in applied settings, also what we're calling applied behavioral pharmacology. At the time, while there had been some research initiative examining this phenomenon, it wasn't a topic that had been extensively studied, something that we uncovered through this reanalysis work. Specifically, this paper aimed to examine overall effects of medication and changes in behavior function that coincided with medication manipulation. Importantly, our second objective for this paper was to see whether there was any noticeable impact of frequency of target behavior or problem behavior as informed by post-medication change functional analyses. This work permitted us to tentatively comment on existing research gaps that may be important to highlight given their potential clinical implications. First, behavioral mechanisms are still largely unknown, possibly in part because few overall cases have been evaluated in the context of functional analysis. Second, very few have sought to establish processes to examine adverse side effects objectively. The two studies listed here are the only ones that I've come across that have aimed to do this. So in 2005, Marie Valdivinos and her colleagues, they evaluated whether tardive dyskinesia was socially mediated. So tardive dyskinesia is a side effect associated with some antipsychotic medications, specifically some movement disorder that causes a range of repetitive involuntary muscle movements in the face, neck, arms, and legs. And what these authors found was that it wasn't socially mediated, meaning the things outside in the environment, the access to attention or access to something in their setting wasn't keeping the behavior going. What they did find was that in certain functional analysis conditions, so there are assessment conditions that we conduct across this assessment, they coincided with the decreased instances of tardive dyskinesia behavior, specifically those conditions where gross motor tasks were being instructed, and that's called an instruction or demand condition. So in other words, they noticed that when participants were engaging in gross motor tasks, rates of tardive dyskinesia did tend to decrease. This could be meaningful from an ameliorating perspective because behavior analysts could support the client by creating a schedule where they may incorporate periods of continuous gross motor activity throughout the day with the specific intent of offering reprieve from experiencing these involuntary and likely quite bothersome actions. So although sometimes tardive dyskinesia symptoms can't be addressed, behavior analysts could be able to arrange the environment such that it could help offset some of that discomfort. Third, exploring adverse side effects as it relates to medication efficacy hasn't been done. So this could be problematic because side effects could manifest as challenging behavior. For example, dry mouth could evoke a liquid-seeking behavior and the individual becomes aggressive if they're denied access to drinking from unhealthy sources like a toilet or a mud puddle. So it looks like the medication has a negative effect on behavior, but in fact, it's the side effect. Another extremely understudied area, examining medication, it includes examining medication influence on preference. Currently, to my knowledge, examining how medications affect an individual's preference, so the things that they like, do, eat, engage with, has not been examined for this clinical population. Regarding medication influence on adaptive behavior, I've seen posters on this, but no publications to date. So some informal evaluations of overall adaptive behavior through proxy reports have also been done, but nothing really comprehensive, where we're objectively evaluating client productivity or adaptive behavior, as we often refer to it. So it is possible that behavior analysts may be well positioned to systematically look at this through establishing working relationships with prescribing professionals. Although research initiatives may be beyond what a typical practitioner could accomplish, certainly setting up a systematic monitoring approach to keep track of adaptive behavior for an individual client or several individual clients on a caseload may be doable for a behavior analyst working closely with a prescribing professional. This is especially important in working with clients receiving maybe early behavioral intervention, where skill building is the primary goal at this early stage, and monitoring how medication prescriptions may be differentially affecting skill acquisition will be an important factor. Unfortunately, as evidenced by the results of our more recent review on the topic, the Cocar et al. 2023, not a whole lot has changed. So pulling all of this together, I wanted to create and evaluate a medication monitoring training for behavior analysts, in part because although the basis of the data collection skill set are ingrained in registered behavior analysts, their application to medication monitoring may require additional training. Through this work, leveraging what has been established to date, I created a medication monitoring tool for behavior analysts and this tool formed the basis of a training package. Through this work, we utilized behavioral skills training, which is a training framework comprised of the following elements: didactic, modeling, rehearsal, and feedback. And this was done to teach behavior analysts to consider relevant psychotropic medication properties in the context of developing a systematic assessment plan to monitor medication effects of behavior. Of course, as part of the training, it was heavily emphasized that behavior analysts reach out to pharmacists and or the prescribing professional to ensure accuracy around the relevant psychotropic medication properties that would underlay their monitoring system. So there were 12 items in the checklist, and notably the final list that had been curated after an early iteration had been reviewed by a psychiatrist. That's actually Dr. Nicholson who reviewed. That's how far back this is going. And 2 additional behavior analysts with experience working collaboratively with a psychiatrist across several high needs cases. So for step 1, users are advised to develop at least 3 to 5 questions to pose to caregivers, which may help the caregiver conceptualize and prioritize their treatment goals, which may help the caregiver then relay these goals to the prescribing professionals. Things like, what do you want medication to do for John? Or what does a successful intervention, pharmacological, look like to you? That is, what kinds of behaviors would lead you to conclude that the medication is or has been successful? And the reason for this is because caregivers may expect too much from a medication, or the objective becomes a moving target. For example, the client may objectively be doing better, but still causing some trouble. And so the parent, without setting a reasonable and objective definition of success, may feel the medication didn't do anything or didn't do enough, and then we might get into increased dosages or polypharmacy, etc. So it's helpful to keep caregivers accountable for what they identified initially as success. And it also maybe help generate more realistic goals. That is, some medications are being used off-label and their impact isn't guaranteed. For instance, an individual who engages in fecal smearing without a co-occurring mental health diagnosis, it may be unreasonable to expect a psychotropic medication to completely address the behavior. So developing these questions and getting stakeholders to answer them may indirectly help folks manage their expectations. Step 2, we want to determine either 1 or 2 topographies, challenge behavior topographies, because it is not feasible to plan for objectively collecting data on 6 or 7 different topographies. So we really want to target those things that are going to have the biggest impact on the learner's quality of life. Steps 3 and 4 encourage behavior analysts to gather information from prescribing professionals around select characteristics that they may then use to inform when and how often they may enact assessments, perhaps things like half-life and steady state. In the planning phases, behavior analysts are thinking about what kind of measurement system. So they're encouraged to first operationally define the behavior. What is the behavior look like? And from this, select the appropriate behavioral dimension to use. For example, are they looking to collect probe data? Just snippets of time. Are they looking to look at duration data? So how long an episode is, and they're recording that about that information about the problem behavior. Are they looking at rate? Which is the frequency of the behavior divided by time? How often and when they may enlist frontline or people like caregivers, educational assistants, instructor therapists, group home staff to collect the data is also something to consider and confirm during this phase. These decisions may be informed by some of the medication properties that we noted, that I noted earlier. So everyone forgets about adaptive behavior, but it's truly important to have some measure of how the meds are affecting folks' adaptive behavior performance. As a side, some basic literature has explored the effects of antipsychotics, like chlorpromazine, and it's indicated that behavior learned in a drug state is sometimes no longer performed when the organism is no longer taking that drug. So apply this to a client. Perhaps you taught them some variation of a functional communication response or some skill that may serve to offset the likelihood the behavior will occur, a replacement behavior, if you will. And they did this after the client was prescribed an antipsychotic. So there's your drug state. And the client is now doing well, and physician discontinues the medication at the behest of the family. And following this, the client no longer engages in the functional communication response, and we see problem behavior reemerge. The conclusion that might be drawn is that the medication is the reason the problem behavior went down, and so it needs to be reintroduced. But it could also be that the learned functional communication response in the drug state, aka after the medication was introduced. And so the removal of the medication without reteaching that skill in the drug state could be the reason they aren't performing it. And we see this reemergence of problem behavior. So this might not be something to think about in the context of medication changes. So back to this list here, I did digress slightly, but I don't think it was too much. So obviously we are establishing a data collection strategy to monitor challenging behavior, and then as well the adverse side effects. So as a reminder, there are some ways to objectively capture adverse side effects, and one can also incorporate them into existing assessment conditions. And we're going to get there when I start to talk a bit about streamlining data collection, because I think by now people are probably like, oh my God, this is so much. It's not, I swear. I swear it's not. Okay, so step 8 for behavior analysts, as far as the tool goes, is to select a functional analysis type, but also looking to item AC or 8C, sorry, you can see that at the bottom of the slide here. The tool encourages clinicians to consider setting events, things that might affect functional analysis outcomes. For example, there is literature to indicate that sleep deprivation differentially affects behavior function. That is, when an individual didn't sleep well, their behavior serves a different purpose compared to when they had a good night's sleep. Keep in mind, this is not to do with rate, although certainly that relationship has been demonstrated to exist. What I am referring to is a good night's sleep may not coincide with reduced instances of challenging behavior, but instead it affects the why of the equation. So why the individual is engaging in the challenging behavior, and neglecting to consider the potential confound could affect data accuracy in the context of medication monitoring. This goes for things like allergies, illnesses, untreated medical issues, dental issues that have been untreated, things like that. The final domain of the tool encourages clinicians to consider how they might streamline their data collection system. Of course, being comprehensive is advisable, but time is finite, and clinicians and providers, care providers alike, can't spend endless hours collecting data. So streamlining data collection can go a long way to ensuring reliable data is obtained and may increase uptake and or capitalize on limited resources. Some examples of streamlining. So in a case where medication could incite attentional problems as a side effect, for example, perhaps the behavior analyst could monitor objective behavior indicative of non-attending, like the client's capacity to focus on consecutive tasks. A pre-medication assessment might show that the client can sit and engage for 4 minutes, while an assessment conducted post-medication change might showcase only 1 minute of consecutive engagement. In a functional analysis, the clinician would be conducting an assessment condition wherein a sequence of consecutive instructions are being placed, and the expectation is that the learner engages in these tasks. For individuals who engage in challenging behavior to escape instructions, maybe I don't feel like brushing my teeth, so I'm just going to throw the toothbrush across the room and punch her in the face. We would see potentially problem behavior occur more often in this context compared to other conditions. But apart from that, if there are milder forms of unrest or disgruntledness by the learner, but you're also noticing that they aren't able to sequentially attend. Maybe they're up and moving around a little bit more as indicative of restlessness. Some of these more objective behavioral indicators can be gathered at the same time as you gather information about the challenging behavior in a very structured way through this functional analysis. And so that's just kind of one example of many that I'm talking about when I reference kind of streamlining data collection. Step 10 is just encouraging behavior analysts to hold off on behavior support plan changes in the event that medication changes have been enacted. And the idea is to limit changes that are happening concurrently so that if an effect is observed, folks will know which change incited said effect. So finally, behavior analysts are encouraged to briefly summarize describing their data collection. I said 12 steps and it's actually 11, but I think it's because I counted one and then it doesn't actually have its own step because it's like a sub-step. So I apologize for that. I just realized it. I was like, oh, and I didn't even went right past me. Anyhow, so briefly summarizing kind of the plan so that other professionals and care providers might better understand it, and then they can see from the behavior analyst perspective, they can showcase that the other professionals and caregivers who've kind of been talked to about this plan, their thoughts have been embedded in it. And so it's a kind of a collection of everybody's thoughts and considerations when you're moving forward with a plan around data collection. So in closing out the section, the tool was meant to serve as a roadmap for developing a systematic monitoring approach, wherein the resulting data may be presented and potentially utilized by prescribers as they work with patients to address challenging behavior via psychotropic medication. So this topic of collaboration isn't new to the field of behavior analysis. There have been a series of publications describing ways to leverage this partnership, including iterating what I've discussed as it relates to medication monitoring. One underlying theme, perhaps not surprisingly, is that all stakeholders should be made aware of intervention changes, whether those changes are behavioral interventions or psychotropic medications. Another related recommendation is that professionals consider how or whether the changes that they're recommending in their area of expertise, so medication behavioral, impacts the concurrent interventions at play. Interestingly, one area for future research described by Newhouse-Oyston is that researchers investigate the effects of interactions between the intervention approaches. And this could be interpreted as examining the combined and separate effects of behavioral and psychotropic medications. In an attempt to address this, and also, as it turns out, serve as a demonstration of a successful partnership with psychiatry, my colleagues and I published a paper entitled, it's a mouthful, Demonstrating an Analysis of Clinical Data Evaluating Psychotropic Medication Reductions and the ACHIEVE Program in Adolescents with Severe Problem Behavior. So here, the team, including Dr. Dyer, who was the consulting psychiatrist for the Adolescent Residence and Treatment Facility for individuals with severe challenging behavior, looked at clinical data that were collected over many months. We were able to answer several clinical questions related to the impact of medication and or behavioral interventions that the team had. And we did this by using effect sizes, conditional probability, Spearman correlation, and non-parametric partial correlation. The outcomes of this work served to inform practices at this institution and also gave clinicians insights into the potential separate and combined effects of psychotropic medication and behavioral intervention for select learners in their program. And the behavioral intervention strategies that they applied was a general kind of sequence of steps, and they called it the ACHIEVE program. So that was for these learners there. Did I go? No, I didn't. So right now, my team and I continue to try to address some of the existing gaps described earlier. An ongoing project entitled Evaluating the Impact of Psychotropic Medications in Persons with Intellectual and Developmental Disabilities Who Engage in Challenging Behavior, again, very long, I do apologize, features a clinical research protocol. That is, the way we set it up maps onto certain steps that are described in the tool. And these steps also tend to be best practice. They are seen as what we would consider best practice in terms of monitoring challenging behavior. So like I said, largely the methodology follows the checklist that I've reviewed with you all. The reason we did this was for uptake and feasibility purposes. So we may be more inclined to create partnerships with agencies and interested prescribing professionals. Essentially, the protocol calls for a functional analysis to be conducted during the baseline medication phase and follow-up functional analysis every time another medication change occurs. The shift from the existing literature, the 2015 paper that I talked about, believe it or not, that was 10 years ago. And since then, I think only 15 cases have been added to that literature base. And I personally contributed to 7 of those published cases. So this is still not something people are doing, sadly. Anywho, where was I? Right. So the shift from this existing protocol, this protocol is different from the existing stuff, is because we're using any functional analysis variation. So because I don't have time to kind of go into the laundry list of different types of functional analysis that there are, but what we were able to do is build some flexibility into the protocol so that if you were supporting a client with a target behavior in real time that is not conducive to the way that a standard standard functional analysis is run, then you can use an FA variation that may be better suited to assess the challenging behavior topography that the learner is presented with. One example of this is a flopping behavior. So some of you who may have experience working with this population may see a learner who decides, nope, I'm not leaving the store. I don't care that it's closing time, and they're 300 pounds and they're 6'5", 18-year-old, and they just flop. And you cannot move them. They will not be moved. Any of Princess Bride fans out there. So that said, that isn't a great topography. It doesn't really fit well with the standard FA. And so there are other ways that you can assess how and what the reason or the purpose of that behavior is for that learner. So we also lean in this research that we're doing right now on several indirect measures like the aberrant behavior checklist. Some of you may be familiar with that, as well as the behavior problems inventory revised. And we wanted to answer another research question here. And that is, do the results of the ABC and the BPIR align with those generated by the functional analysis? So we're kind of looking at that convergent validity. The third point of data collection in this project is daily data. So if a learner is working or is at a group home, or they're working with an agency where they're being provided day program support, or maybe even at home, they have supports in the home that wherein data are reliably being collected every day. We may be looking at, again, that convergent validity piece between what is the daily data saying compared to the functional analysis outcomes. And is there any relation, or is there any kind of correlation between those two? And the purpose for that is just to see if we can, again, look at streamlining. So if some of these assessment strategies are replicating or correlating with others, maybe we can drop them. So if daily data, for example, is reliably correlating with functional analysis, meaning they're basically saying the same thing, then maybe we can say, you know what, guys, unless it's like a really severe incident, don't bother ticking, how often it's happening. We'll come in once a month or once every time a medication change happens. We'll do the FA. And now you're taking that burden off the care providers on the daily basis. Of course, if there are, legal reasons you need to collect the data, if you're working with an adult population in group homes, there's things called serious occurrence reports where if something really untoward occurs, you have to report it to the ministry. I'm not talking about things like that. I'm talking about, ongoing daily data collection, but that were only if these data collection systems are actually related and they're kind of saying the same thing. They're giving us the same message. So the other neat and entirely new question is to do with preference stability. So no one has ever objectively monitored how medication affect preference. And this is important to us because we rely on reinforcement, et cetera, to promote adaptive behavior. And if a medication affects an individual's preference, we need to know because our programs need to be adjusted. Once again, this protocol aligns well with clinical practice. Once per week, the individual would complete a preference assessment featuring leisure stimuli, a preference assessment featuring edible stimuli, not that kind of edible, things that they like to eat, and a combined stimuli preference assessment. So we put together their top preferred leisure and their top preferred edible, and we look at what stimuli type they prefer more. And if you have, so the piece to note here is that we do run this assessment. We try to, as best as we can, on the same day at the same time each week to control for medication factors as well as other factors that could affect the assessment outcome. For example, if you have a fast-acting medication, it's possible that running the assessment at different times could confound your results based on the level of that medication in that learner system. In reference to other factors, this might be things like running the preference assessment right before lunch one time and then right after lunch another time. So it's like, oh, I'm already full, and now you're giving me this array of goodies. I'm not interested in any of it, as opposed to I am kind of hungry right now because my lunch is coming up and I haven't eaten since breakfast. Yeah, I'm really interested in eating some of these foods. So we try to control for factors as best we can that way. We are hopeful that the methodology employed, albeit slightly less rigorous from a pure kind of research perspective, may still yield important, potentially more ecologically valid outcomes so that we can continue to examine the under-researched area. we are hopeful that partnerships developed along the way may really help push this agenda and ultimately improve client well-being, which is honestly at the heart of the work that we do in my lab. So to end, here's a lovely photo of some of my past and current students. I'd like to thank everyone again for your attention, and I am so happy to answer any follow-up questions that anybody has. I will just leave this slide up in case you do want to click on the website or quickly jot down my email.
Thank you, Alison. That was fantastic and really highlights, I think, an area that we as physicians anyway haven't often, well, have neglected, including other professionals in assessments. And, when a few years ago when we were, well, I was a very peripheral person, but Allison and Louis Bush had created the Ontario guidelines for applied behavioral analysis, I think. And in my sections around medication, I had written, that the role of medication is to enhance or facilitate other interventions. And one of the questions that Allison asked was, well, what evidence is there for that? And I think that's a huge question. And in the psychiatric literature, there's very, very little studies have ever done that, unfortunately. And they tend to be very, very short-term studies as well. Often, because for drug companies, all they're interested in is FDA approval, really, which is 12-week studies a lot of the time. And so they don't tell us about long-term benefits or long-term side effects. I guess one question that I would have, Allison, is if the most common reason people come and see me, and I see most physicians around in this population, at least around medication, would be about aggression and self-injurious behavior.
Yeah.
And I think that, the function analysis is great, but we're not always going to have access to those people.
Yeah.
And I think that it's not, I want to make effective use of people's time as well. And so if we're asking people at schools to get information or for parents to get feedback from schools about things, because we want to get in multiple environments, how would you suggest going about that?
Oh man, my first suggestion would be lean on the people who have your funding and say, get me a behavior analyst. No,
Yep.
Of course. I think and this is why we try to do the convergent validity piece, because if there is some overlap in terms of if there's a system that's in place to collect information, even things like serious occurrence reports. If you're dealing, I know you deal with children, but some of your colleagues we were talking before deal with adults, and the ministry does require that if there's something really bad that happened, they have to write a serious occurrence report. So you might actually ask for something similar from the school, because if there is an incident where the learner elopes and they can't be found for X number of minutes, or if the learner attacks another child, that has to be reported somewhere. It has to be recorded, because they would have some sort of incident report system. And so you could ask for the structured, like the worst of the worst. You can say, give me those incident reports. And at least you'd have a tally pre-post of something like that. If you were really hitting it, if you were making kind of a broad stroke change, you might be able to see differences in how often it happens. And it's possible that there could be some sort of overarching legislative requirement that could help you access something that's a bit more objective. You could ask for something specific if you have like you've all attended this talk, so you have an idea of like what would you want to know to determine whether or not this was the right way to approach this. You could ask specifically, okay, parents, I want you to go home and say property destruction was the issue, and I want you to take a picture of everything that they destroy in the next week. That's it. Just take a picture of it and then bring it to me. And so what you get is now a tally, and you get the level of the intensity of destruction. So if you're looking at things that are posters that are being ripped off the walls, okay. But if you've got a door that's been ripped off its hinges, right? You've got intensity, and you've also got frequency, because they've taken a picture of everything that the learner has destroyed, a permanent product, if you will. So that could be another way that you could get parents thinking about, okay, how can I do this? I'm very busy. I have 3 other children that I'm trying to protect at the same time. It's not like a big deal to be like, everyone's glued to their phones. Like, come on, you can't tell me your phone is in your pocket, just a quick little snapshot of it. That might be a way to get some data.
And I think I like that idea, because especially the one about the incident reports, because there's not really any objectivity to that. It's a 0 or it's a 1, right? There's no opinion, there's no subjectivity. And I think that's what we really want. That I think it's a great outcome measure because I've said for quite a while, that I think our outcome measures often in psychiatry are not great because they're all subjective at some level. And so having something that it's really straightforward and doesn't involve opinion would be a great way to go. I think
You
it's
can also do, I'm thinking of self-injury because I didn't really touch on that. You could also do pictures of self-injury, like in terms of like, say there's a spot that they target, and maybe once every other day, you take a picture of how red it is, right? Like, because the parent can't count and like they're trying to block and they're trying to keep the learner safe. And so there's a permanent product for how much damage are they doing week over week compared to after we put them on this medication. So that again could be another more objective way to reflect on how things are going with the medication.
Yeah, that's a really great idea. Thank you, Alison. Dr. Goldberg, wonderful to see you. If you want to, I will unmute you. Oh, actually, no, sorry, I'm chatting there. Uh,
Hey, can you hear me okay?
oh, yep,
I'm okay?
Yeah, I can
yep.
hear you.
Okay. I think that it was very important uh, that Dr. Cox raised the what happens after one prescribes a medication. This year is about the 120th anniversary of the first child guidance clinic in Chicago, which was made up of doctors, psychologists, and social workers, and it was aimed at the delinquents. I can't conceive with a developmentally disabled uh, youngster or adult, a psychiatrist or physician working without having a psychologist to be able to monitor the behavior. And I think you've outlined it very well in terms of the functional analysis. But I think one has to add on the social worker and communicating with the parent in terms of what is the effect of the behavior on the parent and the parent's intervention. So just want to add that particular component. Later on, for example, at CPRI, you add several other members to a team, occupational therapist, physiotherapist, dentist, and all of these contribute to the behavior as well. But I think the importance of following up the effective medication with the functional analysis is critical, but one does need to add the other components as well, knowing the history of child guidance clinics. So thank you very much for reminding us it's a team that works and not a solo.
I appreciate that. Thank you so much. Sorry, I had to move back from my computer because my husband brought my daughter home and she will just bust in here. So I locked the door. All right.
Yeah, but Ben, that's one of the things that I learned from you myself over the years is that as psychiatrists in this kind of population, we're really part of a team. We're not running things and shouldn't even be thinking of ourselves as that because the most important interventions I think are really not medical, but other things. And so including other people and getting information from them is critical in a lot of into the whole enterprise. Sean, I don't want to put you on the spot, but I'm going to anyway. What comments would you like to make to Dr. Cox? Assuming that you're actually there. And now I've called him out and he's not there. That's not good. Anyway, other questions or comments for Dr. Cox? Alice, if I can ask you, so over the years, I think, well, I have opinions about this, but what do you think have been some of the barriers to having truly interdisciplinary or multidisciplinary teams with these groups of people?
Unfortunately, I'm going to say something we can't do anything about: funding. I think funding does interfere with our best efforts to try to have all the right people in place. But I have also experienced where some prescribers don't even know about behavior analysis, or they don't know about other professions that could enrich kind of that that psychiatric process. So I think we've done as a field maybe a disservice by not being a bit more available, or making our science or our profession a little bit more notable. I am hopeful that the registration of behavior analysts as registered health professionals that happened in July 2024, that might help raise awareness about what we might be able to offer in these situations. I did have a conversation once recently with someone who also indicated that the way that billing works, as I understand it, like there's only like 20 minutes for an appointment, or it's very short. And so to add an additional professional might undercut some of the other work that needs to be done in those very brief appointments. So I wonder if the desire just to have an additional person sharing information may not be front and center. So I think as a researcher, my biggest kind of area of a barrier would be access to the participants, and being unable to garner funding so I can get boots on the ground. Like you and I were talking about earlier, I don't think there's an invested interest in supporting this population maybe as much as there should be. And so it is very competitive to try to get the very limited funds to be able to put those paid researchers on the ground running out assessments. I'm just one person, and these assessments do take time. And I don't have the funds to have a full-time behavior analyst running these assessments across weeks. But we do what we can, and we've made some good inroads. So I think just getting that information out there could be helpful.
Well, and so to your point about funding, and it may have something to do with specific organizations, but the way OHIP pays psychiatrists, we get paid by the half hour or greater part thereof.
Oh,
But
okay.
theoretically, I could see, I believe, up to 5 hours a day, which I don't plan on doing with any one patient ever. But
Yeah.
so I think that 20 minutes may be more of an organizational
Oh, I see.
thing,
Fair.
perhaps. And I think it's some places that have undergone their lean reviews or whatever they're called, which really reduce patient care in the long run. I think a problem. The other thing I wanted, I was maybe it was diplomatic of you, honestly. I think at times the hubris of physicians as well is a problem in terms of seeing other people as equals in what we do.
Okay.
And
I'm
sort of,
not going to make a comment on that because I'm not a physician, but I've certainly been in situations where I played very humbly just to get invited to the table. And I was very reserved because that kind of dynamic did seem to be very present. And, I just, want a seat, and I just want to be able to support and engage if I can. So.
but I think that's on us then as physicians, right, to make sure we include all these other things, because we're not, I mean, I think that generally we cannot see people with developmental disabilities individually, and it's not just about medication. And so I think we have to include other people, which is not always easy to get people together and stuff like that, but I think it's something we need to work on more. Sarah, you had a question, and then we'll get Sean as well. I will allow you to talk here, Sarah.
Hi, Allison. Can you hear
Hi,
me? Hi,
I
great
can
to
hear
see you.
you.
Great talk.
Thank you.
So actually, what you guys were just discussing is a great segue to my question. So if there are clinicians or researchers listening right now that are thinking, and rightfully so, that this is fascinating, and how do I get this perspective in my clinical practice or in my research? Where do they go? Who can they contact? Is there a repository somewhere, or what are your suggestions?
Well, first off, me. I'm always looking to enhance partnerships. This project specifically, we've got folks in BC and folks in Nova Scotia who are collaborating with us to try to get some of this research. They are volunteering their time, but they're behavior analysts, and they're running these assessments as part of their clinical practice, and we're being able to use the data for that. So my first thought is, if you have an idea and you want to kind of reach out to see if some of this could work in the context you're working, I would say that's great. I actually don't know anyone else in Canada who's doing something specific to this. There are certainly folks in the States, but the cross-border thing might be a bit tricky unless you're a researcher. So if you are a researcher, Maria Valdivino does some really excellent work. Jennifer Zarconi used to do a lot more. She's now kind of taken on a bit more of an administrative role. There's some work coming out of Louis Hagopian He works with Kennedy Krieger, but he doesn't do this specifically. We are doing a talk together at the conference, the annual Association for Behavior Analysis International Conference, and it is on behavior and meds type thing. But those are the three big names that kind of stick out in terms of kind of who's doing this work. I appreciate that question. Thank you.
Thanks, and great to see you.
But I wondered too, Alison, if this is something you and I and Sean could talk about, something some kind of consortium, because I think one of the issues becomes that there is not necessarily a lot of expertise in any one location, especially for people with really severe self-injurious behavior, in part because it's not particularly common, thankfully. But I think that what happens then is there's little bits and pieces, and we need sort of a combined effort, I think.
Yeah.
And so along those lines, Sean, feel free to go ahead, just unmute yourself.
Okay. Thanks, everyone. Amazing talk. So I wanted to ask, is there, do your methods, can they apply to analyzing deprescription from a polypharmacy state? Because that is a very common clinical scenario we run into. And yeah.
Yeah, so they can be used to monitor introducing medication, increasing dosages, augmenting medication, as well as, moving into kind of a withdrawal pattern, or, trying to do a washout, if you will. So it works both ways.
That's great, because I think that many physicians, I'm speaking, at least I would feel a lot more comfort with deprescription if I kind of had a very clear set of data points to know whether it was helping or hurting, because it is a tension that I have seen quite often, where many families want to deprescribe, but they're afraid to deprescribe because they don't want to be at the same place they were 1 year ago. And I feel like a lot of hours that can be spent during appointments might be saved if we just had the data. And it's great that your methods, among other things, could be used for that.
I appreciate that comment, because that was actually one of the questions, the paper that I talked about, the Achieve program. What had happened was they had shifted physicians, because that physician, Dr. Dyer, had retired, and their new physician was very much in that position where she was afraid to I guess you're calling it deprescribe, even though that had been Dr. Dyer's go-to, because a lot of these learners were 16 years old and on 8 or 9 psychotropic medications, and it wasn't helping, because they were there because they had set fire to their home, or they had been evicted so many times that they had nowhere to go. Some of them had been, these are very severe individuals, some of them had been up on assault charges, assault with a weapon, and assaulting a police officer. So these are not small crimes. And so the questions they had were, what is the likelihood that we would see an increase in problem behavior coinciding with deprescription compared to the introduction, compared to no change? And we were able to look, and we were able to see that there was no significant difference for the cases that we looked at in terms of whether deprescription caused kind of instability or an increase in problem behavior. And that was a great way for them to take that template and apply it across many of the learners that they were supporting, to try to build some evidence base around, what can we expect and what can we be ready for. And that was they really appreciated that. So I'm glad you brought that up, because that was definitely number one question on that Wales paper. Sorry, I called the Wales paper, the Achieve program that I worked on.
Good. Thank you, Sean. So a couple of questions. So there's a comment from Vikram Paladasamy. He wrote here in the chat, not a question, but a comment. I work in British Columbia for a health authority. My team is a multidisciplinary team with nurses and behavior consultants. I find the role of behavior consultants very useful in monitoring outcomes when prescribing medications, and also several other roles in my team working collaboratively. I did a video with a couple of behavior consultants, how psychiatrists and behavior consultants can benefit from working together. And that is in the Q&A, but I will also copy it, and I'll make a, I can't. I was gonna say I could try. I will figure out how to put the link into the chat. But there's a question then from Joan Gardner, who's a speech and language pathologist here at CPRI. It's asking at least for children. So can families, in terms of these functional analyses, is that something that is, I suppose, part of a behavior analyst role anyway, in working with kids with behavior problems? but can people use OAP funding to pay for functional analysis specifically?
Yes. Great question, Joan. Yeah, functional analysis is well within the wheelhouse. OAP funding absolutely can be used to pay for that.
And it just needs a pre-approval or whatever?
Well, actually, the way OAP funding is, you find the person, you get the funding from after your dawn call, your assessment needs call, they approve the funding, but then you pay for it and then you submit the receipts. So you would get an invoice from your registered behavior analyst and you would submit that invoice to get reimbursed. So that's how the OAP works. But yes, that is absolutely within the realm of available or acceptable ways to spend that money.
And sorry to ask a follow-up on that. Just wanted to clarify a little further. Can the urgent response funding also go there?
I believe, like the urgent response, I believe it's once you're engaged in that process, you have behavior analysts, so you can request that their assessments include a functional analysis at different time points. So it may be a bit of a negotiation because you're kind of dictating to the URS behavior analyst, what you'd like to see. But I think if they're being invited to those psychiatric consults, I think it's reasonable for the doc to be like, hey, can you run an FA for me? And first of all, I think the BA might fall off their chair, be like, oh my God, this doctor knows, it's amazing. And yes, I can. And you could even dictate the timeline of that. So part of the tool that I'd been talking about was getting that information, like what is the titration period? What's the likelihood that if we start this med now, in 7 days, will it be at its intended level or whatever? And then you could say, okay, well, if you do the FA now, right before we change, then can you please do it again 10 days after after you've started this new prescription? And you could even help them along by saying, this is when I need that information. So that could be a great way for you to help guide some more systematic processes. Oh, Rob, you're on mute.
Sorry, Alison, you have a few minutes to stick around for other questions?
I do, absolutely.
Okay. Actually, before we do that, just in the chat, so on March 27th, we have our annual spring continuing professional development day through the Developmental Disabilities Program, and I put the link there for the information and the registration. And also, the Western Institute for Neuroscience is hosting a child health collaborative day next week to bring researchers together from disparate parts of child health to try and sort of create collaborative relationships. And I also, in the chat, have put the link for that, as well as for Dr. Palanasami's video about collaborations. And also, just before everybody goes, please complete the evaluations. And Jason has put the link in there for that as well. So there's a question then from Alexandra White, and if you can just unmute yourself.
Hi, can you hear me?
Yep.
Yep.
Perfect. Hi, Dr. Cox. Thank you so much for this presentation. It's been incredibly helpful. As a behavior analyst myself, I wonder about how you typically present data in a way that feels that psychiatrists attend to it. Is there a specific way that you would suggest in presenting that data?
Yes, absolutely. So I usually start off with something very vague, just like the behavior got objectively worse. This is the number post, this is the number pre, or vice versa. If the doc, I usually have a couple of graphs ready because I have been surprised before with like, show me the graph. And you're like, oh my God, I'll show you the graph. So if the doc is interested in looking at some of those trends, then maybe have that available, but I would not start with that just because like time and you don't know, what they're specifically interested in. I also tend to ask them what they want me to report on. So if if it's the first time I'm there, I will say, what are the things that will help you make a decision? and they'll list off a laundry list of things, and you can then, make your plan according to what's going to help them make their decision. So you're coming back with directly what they've already asked you to do. So in terms of data, keep it general, with the opportunity to show them how the trends are going, so that you have it available. Make sure it's stuff that they have asked for specifically.
That's amazing. Thank you so much.
My pleasure.
Alison, there's a question here about, do you have the link for the medication checklist tool?
I have yes, I can circulate let me see. I don't think it's open source. I can circulate the paper that we published, and that will have the checklist in it.
So, Jason, if Alison sends it to you, will you be able to forward it to people?
Absolutely.
Okay, that'd be
I
great.
will send it. I'll put that in a note, so I'm not wasting time right now. Yeah,
Yep.
circulate.
So, one question for Dr. Goldberg was about Dorothy Griffiths. Is she still working? Because Ben and she had worked together in the past on self-injurious behavior.
Dorothy's retired. Well earned, and I think she's writing fictional novels.
Really?
That's
Wow.
her new interest.
Oh, good for her.
Yeah.
And then there was a question from an anonymous attendee. So the question was, and I think so why would you suggest doing a functional analysis of behavior as opposed to just asking people to fill out questionnaires or just keep tallies and things?
Yeah. So questionnaires tend not, in the context of a functional analysis, to rely or to report the same rate. For all those reasons we talked about around recency, some of those issues with indirect reporting those biases can find their way into the way that people are reporting and using those. So certainly it's important to incorporate qualitative information on how things are going, but that objectivity, I think, does remove some of those barriers that present with the proxy being bias, recency, what they think is going to happen. And it's just a way to kind of check in on that. The other thing that I find is that unless there's a really structured way that the person is being supported, there's a lot of different things that can happen in their kind of setting that's going to dictate whether or not the behavior occurs. And when you have the functional analysis, at least you have a very structured way. You know that under these sets of circumstances, this is how the learner is going to present. So you are almost pulling in as much control as you can in a largely chaotic setting, and controlling the contingencies in through that assessment, so that you can look as cleanly as you can, trying to remove any of those confounds that can find their way into the data. So things like, thinking about sleep deprivation, allergies, things like that can kind of facilitate that ebb and flow from the daily data perspective. So that would be a way to enhance. Okay, what are we looking at? So that is my kind of consideration around it as a package.
And I think one problem with certain questionnaires around behavior is, there's, I don't even know what kind of bias you would call it, but Catherine Lord had a paper a few years ago. And I think it was about aggressive behavior, maybe in people with autism. I'm not exactly sure, but parents filled out a questionnaire, and then a few weeks later, maybe a month later, filled out the same questionnaire. There'd been no intermediate intervention, and scores went down. And that's perhaps due to recency bias or whatever, but I think it's been found similarly with kids with ADHD that if their parents fill out a rating scale and then a week or two later do it again, scores tend to go down. Yeah. And so that's where you run into difficulties. Whereas I would assume that a functional analysis would be more objective.
Correct. You would be presenting very similar types of situations across all of these medication conditions. So I agree, the inter-observer reliability can be tricky, or it kind of retest, I guess, would be kind of tricky across some of those measures as well. So you're kind of hedging your bets by including something a bit more objective, like Rob was talking about, with some of those maybe even permanent product stuff. So if FAs are beyond, there are some other ways that you can, as a clinician, start to ask for something that would augment some of those indirect measures.
I suppose when it comes back to schools and things like that, though, that we're really not going to have the luxury of doing the functional analysis in the school setting?
It depends. Some of the schools have some behavior analysts on staff who will run it in the school. So if that is an option, I might suggest asking for that, especially if yeah, if you know that this is a high needs case and they have a behavior analyst who's largely they're like kind of prioritizing this case, I think it is reasonable to ask that be done in and there, like I said, with the functional analysis variations, there are safer ways to be able to run this. There are trial by trial assessments, which means you terminate it after a very short period of time. There are things called like latency. So there's a lot of different ways that you can make sure, because people think, oh my God, there's other kids in the class and this and that. You're not evoking kind of like that high, I'm tearing down the ceiling behavior. You're evoking kind of earlier behaviors in that chain that suggest agitation, so that the learners in this space are not immediately at risk. And a lot of these learners who are coming to see physicians and psychiatrists a lot of them might be in their own spaces, or they're already being isolated from their peers because of their agitation or because of their self-injury. So it wouldn't surprise me if many of these learners have spaces that are their own designated spaces, and then the safety element around the other learners in the classroom becomes moot.
And I think obviously I can only speak for London here, but I know in the Thames Valley Board and maybe the Catholic Board, I'm not sure, that they both do have behavior analysts, or the public board for sure. But I think they are really is a tremendous demand, and so not really available on demand that way. And so what you said was great, but there's a lot of ifs in there, right? So if there's somebody involved, if they're working with them right now, kind of thing, which would be ideal. But
individuals.
I think that creates the difficulty. The other question, Alison, is, how do you know, and maybe this is a silly question, but if you do a functional analysis, let's say a month or two after you started medicine, how do you know that day is representative of things?
If so, you do a functional analysis at the beginning and then say the med doesn't change for 6 weeks.
Yep.
There is some evidence to suggest that function can be and is stable up until 6 months. So it's very limited, but there is some early and some more recent research that suggests that, especially in the context of self-injury or automatically maintained challenging behavior, function will remain stable. The most recent paper on it was in 2020, I think, and they had demonstrated that automatically maintained challenging behavior remains stable across a year. So I think there is some built-in assumption there, like you're saying, oh, how could it? And this is also why you need to stay on top of the behavior support plan as well. So if there is a behavior support plan that's concurrently functioning, it could change the outcomes of the functional analysis. And so knowing kind of when those changes from the behavior support plan made their way into the learner's world is going to be really helpful. So maybe you have a functional analysis done pre-med, and then you have some behavior support plan changes and you keep the med constant. Maybe you're assessing behavior during that, and then you do your post-med FA and you see 0 rates occur. So the learner is able to tolerate those conditions beautifully. And then you might say, okay, well, we've done some good work here. We don't see that in the conditions. So what are our next steps? So it still is a talking point. There is still some uncertainty because you don't have control over everything, but I do think it is a lot more structured than just kind of,
Yep. Yeah, I think that's a real problem with tallies and stuff. Is sometimes just having a piece of paper and a checklist or a clipboard and a pencil there when things happen might not be always easy, and then people have to remember it.
Yeah, absolutely.
All right. Are there any other questions for Dr. Cox? You've gone over time, Alison. I appreciate you sticking around.
My pleasure.
So again, Alison, thank you. This was a fantastic talk and has created a lot of food for thought. Certainly, I will be in touch with you at some point, and I know Sean will be also.
Yes, absolutely.
And this was wonderful. Thank you very much. I really appreciate it.
Thank you.
Just one other thing. So our talk next month is on March 19th. So it's the third Wednesday instead of the second, because the March break is the second Wednesday of March. And so on March 19th at our rounds, myself and Dr. Egidio Spinelli are going to present a case and talk about aggression and epilepsy in people with developmental disabilities and sort of pharmacological and behavioral approaches. So thank you again, Alison. That was fantastic. And
thank you for the invitation.
Yep,
Have
be
a good
careful
night,
in the snow
everybody.
out there. Yep, take care, everybody.
Yeah. Bye.